Hello, and welcome to a very special briefcase that is part of a series I am leading on diversity, equity, and inclusivity with CME Outfitters. Today's CMEO briefcase is entitled Maternal Healthcare, Real-World Tactics to Address Health Inequities. Today's program is supported by an educational grant from Johnson & Johnson. I'm Dr. Monica Peak, and I'm a professor of medicine at the University of Chicago, where I also serve as an associate director at the Chicago Center for Diabetes Translational Research. I'm also the executive medical director for community health innovation and a director of research at the McLean Center for Clinical Medical Ethics. I'm delighted to be joined today by my distinguished colleagues, Dr. Heather Irabunda and Sierra McLean Henry.
Hi, Dr. Peak. Thank you for having me here. I'm Dr. Heather Irabunda, and I am an attending physician at New York City Health and Hospitals.
Hi, I'm glad to be here as well. I am Sierra McLean Henry, full spectrum doula, parent educator, and founder of Sankofa Mama Birth Services.
That's such a wonderful name. Heather and Sierra, I am honored to have you joining us today, and I'm really excited for our discussion. Our first learning objective for today is to identify the impact of health inequities on pregnant and postpartum patients. I want to remind our audience that this CMEO briefcase is part of a continuation of our initiative to address unconscious bias, health disparities, and racial inequities. We're building a comprehensive library of educational activities addressing these very important issues, and today's activity continues the discussion in maternal health care. The titles of the activities in this series are on the slides, and the links are in the images. You can simply click on the images to review any of those programs. If you participate in at least 3 of the programs in our D&I Hub, you will also be eligible to receive a digital badge demonstrating your commitment to education on diversity, equity, and inclusivity. As we begin to address maternal health care disparities, I want to just review some foundational points regarding historical racism that remind us all how we got here. We've done previous programs that cover these topics in more depth, and those programs can be found in our D&I Hub. I encourage everyone to participate in our foundational programs so that we can learn and do better. But just to review, we have to sort of acknowledge that there are sort of 3 large buckets that I frequently talk about. One is the existence of structural inequities or structural racism, systemic racism, and how that impacts multiple things, including differential spread of what we call the social determinants of health, which includes housing, clean water, food, education. Structural racism also impacts things like healthcare provider bias. It also impacts things in the community, like exposure to differential things in the social and built environment, differential exposure to environmental toxins that we know are hazardous to our health. So these direct exposures to structural racism are one thing, and then they have an indirect impact on our health, so that we know that chronic exposure to discrimination, for example, is a kind of chronic stressor that then has pathophysiological consequences for our health. We know that healthcare bias results in or can result in disparities in the kind of healthcare that's delivered to patients, or deviation from standards of care for different populations. And so there are ways in which this kinds of systemic racism can begin directly impacting the health of people. And this has long-term impacts for not just the health of patients, but also how engaged patients are willing to be and how we can or cannot retain them within our healthcare system. And the long-term sort of epigenetic effects that we're seeing, not only for our existing patients, but for their children and for other generations to come. So the issues that we're talking about today are just of critical importance that we're continuing to learn more and more about. And so that's the sort of larger framework in which we are discussing our today's topic. So now we're going to jump to our first patient case that we're going to discuss today. Heather, can you tell us about our patient who we're calling Macy?
Sure. So Macy is a 30-year-old Black female. She's a G3P2. She's 33 weeks gestational age. At her prenatal visit with a new provider, her prior OBGYN retired. She's 5'4" tall. She weighs about 198 pounds. Her BMI is 34. She has 2 small children at home, ages 2 and 6, and has a partner in the home, but he travels 3 to 4 days a week. She also states that she's feeling unusually sad and overwhelmed and has anxiety about her lack of consistent childcare. She said that I am struggling and I am not as excited as I was in previous pregnancies. Her OBGYN responds with, that is normal with 2 children at home and you're working. Try to slow down your weight gain at this stage, but your baby is healthy and you should be able to have a vaginal birth, though C-sections are more common in Black women. Just get some rest and don't worry so much. Macy returns home crying and tells her husband she felt unheard. She is upset that she has been labeled as quote unquote non-compliant in her patient notes after missing some appointments due to her work schedule.
So before we move on, I just want to note a couple of things that are there in that patient case that have to do with provider bias, either unconscious or otherwise. And so I'm going to kick off, and I just want to sort of see, Heather, what your opinions are, and everyone actually to weigh in. One of the things I study a lot about is how providers document things in their medical record. And so for her to be documented as non-compliant, we recently looked at a study that showed that African Americans were more likely than their white peers to be labeled with negative descriptors, aggressive, non-compliant, all of these things, and that those descriptors were 2.5 more times to be associated with African Americans, but they were also associated with patients who are more likely to be transferred from the general medical ward to the intensive care unit. And so I think that how we talk about patients has implications for future health. What else did you all notice from this case that indicates some provider bias?
I definitely have the same issue with the non-compliant term because oftentimes it's used more, and even anecdotally, we know that it's used more commonly in patients of color, especially Black folks. And something that kind of irks me about it is the reason why for the label of non-compliance a lot of times has to do with work or childcare responsibilities or things like that that are out of the control of the person who gets this descriptor label. So it's like, how can you be compliant if you can't leave your children at home by themselves? Or how can you be compliant if you can't take time off of work, and if you don't go to work, you can't feed your children? So I always find that to be an issue. And then talking about how Black women are more likely to have C-sections than non-Black folks, I think is interesting because it's a multifactorial reason as to why Black women have more C-sections than their white counterparts. And a lot of it has to do with bias and with the inherent issues with our medical system. So I think it's funny that that's kind of like pushed onto the patient, like it's kind of like, oh, don't worry, this is kind of like who you are and what's going to happen to you. And it's not really looking inward to like the medical system that has caused this.
And it's interesting also that, that was just kind of laid there, this is more common for Black women, and ended with, but don't worry, when this has now planted a huge seed of fear, of doubt, of uncertainty in someone who came in reporting already that they were struggling. And so, it's easy for someone who's not experiencing what this person is experiencing to, have a simple to-do list. If you just did this and this and this, things would begin to improve for you. But when someone is struggling with mental health issues, it seems as if that issue is, insurmountable. It dictates how they will carry on in every other area of their life. And, she said she felt unheard, and understandably so, and left not only with her original concerns not being validated, but with new ones.
And particularly because we know that pregnancy and the peri-pregnancy period is associated with an increased risk of depression and mental health concerns. And so to
Mhm.
not actually name that and to offer support and other resources, but just to say, oh, relax.
Yeah, and it also is a reason why many people will shut down and will stop seeking the help that they need. All it takes is, one or two situations of feeling unheard or feeling belittled when you express your concern or, being told, oh, this is what's really important. What you really need to focus on is this. That could cause this patient to never again reach out for help. And then we see someone go into the postpartum period and we're surprised that they're struggling or that they may be dealing with some anxiety issues or depression postpartum when the signs were there in pregnancy, and what it would really do to help this person who was reaching out.
Absolutely. Thank you so much, ladies. So we're going to now turn to our first audience response question. Um, in the United States in 2020, the maternal mortality rate for non-Hispanic Black patients was how many times higher than the rate for non-Hispanic white patients? So the unfortunate reality is that maternal mortality is on the rise. Heather, as an OBGYN in New York City, do you see these sorts of numbers?
Oh, we definitely do. It's actually in some parts of our city, it's even higher than the national average. And a lot of it has to do with, it's multifactorial, as we all know, but a lot of it has to do with like systemic factors, the social determinants of health, and how that impacts Black birthing people in our communities. And so in parts of the city where you have higher numbers of Black and Brown folks, we do see higher rates of maternal mortality, especially in Black birthing people there. And so it's really distressing because you see higher rates of predisposing conditions. So things like high blood pressure, hypertension. We see higher rates of diabetes, higher rates of people entering their prenatal care later in the pregnancy, and things of that nature. And it's really unfortunate, in addition to some of the biases that some of the medical providers in these areas have towards the patient. So, for example, seeing a lot of things like non-compliance in the chart, when a lot of this stuff is due to systemic factors that cause the patient not to be able to come into their appointments or to be able to stay when we tell them you need to stay inpatient for certain procedures or, things like that. So we definitely see this in New York.
So thank you. And if we take a step back from just New York, when we think about the United States as a whole, we know that the maternal mortality rate for non-Hispanic Black patients was 2.9 times higher than the rate for non-Hispanic white patients. And currently, Georgia has the worst maternal mortality rate of any state in the country, where Black women are 3.3 times more likely to die from pregnancy-related complications than white women. In what ways does Georgia, Heather, maybe you can talk about this, reflect the maternal health of the country, and in what ways does it differ?
I mean, it directly reflects what we're seeing in the country, because I feel like every part of the country kind of is a little microcosm or a little like micro piece of the puzzle. And in states like Georgia, so Georgia, Mississippi, places like those with higher percentages of Black people, the Black population is higher, you tend to see worse outcomes compared to other parts of the country. And unfortunately, it has a lot to do with systemic racism and barriers to care and social determinants of health. But that's what we tend to see, is when we have states with higher percentages of Black folks in them, we tend to see higher rates of things like infant mortality, low birth weight babies, maternal mortality, things of that nature.
Mm-hmm. Yes, exactly. And I think that in this next era, sort of post-Roe, we're going to be seeing a lot, an exacerbation of these numbers.
Oh, yeah. And something to also mention is that these markers, looking at maternal mortality and infant mortality rates are just markers of overall health in our communities. And so by seeing this, because we tend to treat our pregnant people, our pregnant moms, and our babies better than anyone else in the population. So if you see these numbers for birthing folks and babies, you can only imagine what's happening to non-birthing folks in the Black community.
Absolutely. Sierra, you're heavily involved with advocacy, research, and reform within maternal health care. What are some of the disparities in maternal health seen throughout the United States?
Well, what's sad is that in those same communities that Dr. Irabunda was speaking about, we see, the widest gaps between services like doula support, childbirth education, things that we know can make a difference in those maternal health outcomes. We see the widest gap between the folks who really need it and those services. They're inaccessible often for these communities. And, even when we are putting policy into place to try to make those services more accessible, a lot of times those programs, expanding Medicaid coverage of doulas and things of that sort are still missing the mark. And so for many communities that are suffering the most, services that could really improve their chances at life and having a greater quality of life are still deemed to be a luxury and just are something that's unattainable and out of reach.
Absolutely. Absolutely. Thank you all so far for this wonderful conversation. We're going to revisit our first audience question and see if we've remembered some of the numbers that we've already talked about. So in the United States in 2020, the maternal mortality rate for non-Hispanic Black patients was how many times higher than the rate for non-Hispanic white patients? So before we move on to our second learning objective, I want us to take a moment to touch on the impact of a post-Roe v. Wade world and what that may mean in regards to health disparities and inequities. And I was just sort of alluding to that earlier. Sierra, can you talk a little bit more about this?
Absolutely. So what this has done, what I've seen in my own practice is create a population of women who are, and birthing people who are just afraid. They are afraid to even enter into the space of becoming a parent, not knowing, what is going to happen. As I mentioned before, there's already a lot of gaps in terms of things like Medicaid coverage. And now without the protections that Roe v. Wade provided, there's a whole population of folks who are out here floating. I've seen so many different things out there since Roe v. Wade was overturned in the way of, believe it or not, do it yourself procedures for ending pregnancies at home. I've seen a lot of information being passed around in the birthing community and amongst birthing people and parents. And that's a scary situation. There are folks who come for services, for doula support, to support them following the loss of a child, whether it's an elective loss or, whether it was not. And, just knowing that they no longer have those protections has really limited the folks who would reach out to get support. Whether or not you choose to have an abortion, you do deserve to have support and to have your mental health needs acknowledged and validated. And there are folks now who are afraid to even speak up at all. I've definitely noticed less folks reaching out for loss services, for abortion support services, of course. And there's also just a frantic search for information out there. There's no centralized place for people to look to really understand what's next, where to turn. And it's sad for the birthing world, for the birthing community, and for the rights of birthing people, period.
Thank you. Thank you for that insight, Sierra. Our second learning objective for today is to individualize a holistic treatment plan for maternal care to improve patient and infant outcomes. So let's check back in on Macy. Heather, I'm going to let you pick it back up.
All right, so Macy's now at her 2-week postpartum visit. She delivered a healthy baby boy via C-section despite prior vaginal births. She feels like she failed due to having a C-section. Macy feels guilty that she's not happy about the birth and feels unconnected to her baby. She stresses that she is experiencing an overwhelming sense of sadness and anxiety about her ability to address the needs of an infant while caring for 2 small children at home. And her OBGYN says to her, your baby is healthy and there is a lot for you to be happy about.
I'd like to jump in here on that last section. Your baby's healthy and there's a lot for you to be happy about. I've come across countless people who have birthed, and it may be years from the time that they birthed, but that spot inside of them that was wounded from the trauma of their birthing experience was never healed. It was never acknowledged. And even refusing to acknowledge the fact that, hey, this was disappointing, this isn't what you wanted, and it erases you as a person. Besides your identity as a mother, you as a human being, it says you can't acknowledge that hurt, and it reinforces this harmful stereotype that motherhood is martyrdom. And once you birth someone through your body, your thoughts, your feelings, you as a person, besides as caretaker for that child, doesn't matter as much or at all, and that we should just carry on and suppress whatever we feel. It sets us up for a lifetime of mental health issues, suffering, depression. And what it does is actually create the same cycle for the next generation.
Yes.
We end up modeling that for our children, and that's the example of motherhood or parenthood that they saw. And so they take that and it informs their entrance into their own parenting journey.
Yeah, so could you all, and you've already done it, but can you explicitly tie that back into our learning objective? So what you guys are talking about, how that specifically ties back into the idea of a holistic treatment plan for maternal care.
So I actually have something definitely to say about that, especially to providers like OBGYNs, midwives, things like that. From a medical perspective, we're always taught like we're looking objectively at like kind of the outcomes, living, dead, like healthy, not healthy, things like that in a binary, right? And even not even taking into account mental health in that, right? So people count as a win that the baby came out, healthy and mom is alive and doesn't have any major physical issues, but not acknowledging the whole part of the person and not acknowledging what their desires were beforehand and then what ended up happening and how they could feel afterwards. That is part of holistic health. And that's something that we need to do a lot better with, especially for our marginalized folks, especially for Black women, Black birthing people, because a lot of times, especially if they have a lot of social stressors in their lives, you may be the only one who's addressed that concern with them, where it's like, hey, I thought I was going to have a vaginal delivery. It didn't happen that way despite my best efforts. And I don't really have anyone else to talk about this with. And I'm just supposed to like trudge along. And this is a great opportunity for us to provide better healthcare to our patients by acknowledging, hey, as much as, yes, you should be happy that your baby is out and healthy, but I understand that this is not how you wanted this to go down, and let's hold space for that. So I think it's really important, because I don't think we do that very often, because we're not really taught to look at that situation that way.
Absolutely. Absolutely. Thank you all so much.
It just reminds me of, I'm sorry if I may share, it reminds me of a client who had birthed, and within the hour of her baby being born, she was crying, a very similar situation to this patient case. And her OB's response was literally, chin up, you'll be fine. And then she walked out of the door. And that just to me illustrates exactly what Dr. Abunda was saying. We have to do better. We have to do more.
Yes, yes, absolutely. And underscores, particularly for those marginalized people whose existence in the world is frequently one of not being heard, of being ignored, of having our concerns not met. So we have so much to cover, too little time. So we're going to, so before continuing our discussion, let's see our next audience response question. Which of the following recommendations is endorsed by the American College of Obstetricians and Gynecologists, ACOG, regarding perinatal depression? Macy's mental health appears to have been impacted during pregnancy and now postpartum. Sierra, why should maternal mental health be a core focus for providers and patients alike?
Mental health, physical health are all connected. And again, it goes back to a holistic view of the healthcare that a person needs in the pregnancy year. We are more than just the physical symptoms that we are displaying. And if we ignore the struggles that someone is having with mental health and we leave them to their own devices, it's likely that we'll begin to see some changes in their physical health. We need to address the whole person, the entirety of what that means, and especially knowing and understanding that, in the postpartum period, even during pregnancy, our mental health can be affected by a number of things, circumstances in our lives, hormones, so many different factors. And so we have to broaden our definition of what it means to take care of the birthing person.
Heather, in addition to evaluating and addressing maternal mental health, how can we as providers individualize equitable care for our pregnant and postpartum patients?
I definitely believe that you have to look at your patient as an individual. It's hard sometimes, given that we don't have a lot of time in our schedules, just given the structure of the medical system right now. And so a lot of times we can feel like we don't have enough time to really deep dive in, or sometimes we may fear like having those conversations with our patients because it may open Pandora's box and, oh, wait, now I'm like however many patients behind or whatnot. But it's so important that we do that. And hey, even if you don't have the time to completely delve into everything, you can start that conversation and then bring in our friends, our allies, our team, right? So that means we can have people like doulas who come in, like especially if they had doula care during their pregnancy, they'll already be well-versed in that, but also they can come in just for postpartum stuff to help folks. In my practice, I definitely use social workers and things like that to come up with a plan. Even if they need a therapist or something, there are people who you can send your patients to help you provide the most holistic care for these patients. Also too, like dismissing people's concerns, although you may like hear the concern and in your mind you're like, well, that's not a big deal. That's a big deal for them, right? They came to your office, came to the appointment and said this to you in that limited amount of time they had to speak. So clearly there's probably a lot of stuff behind that they're trying to tell you. So really listen to what they're saying. And if there's something that they bring up that to you may feel trivial, it's probably not. And there's probably something big behind that. And then also too, just like if you've seen this patient before, and you're now seeing them postpartum and they're saying all the right things, but you notice a change in their affect or how they are, how they present themselves. Those are things you need to be honing in on, because a lot of times people say, well, she said she's okay. Mm-hmm. I mean, if you've seen her before and you're used to her, like, dressing a certain way, and then she comes in and she looks completely not like herself. She doesn't sound like herself. You need to dig deeper. And so it's our responsibility for our patients to look into these things, because we may be the only person who notices this. We may be the only person who sees them during this time, and you can connect them to such great connections and great resources to help them get through their postpartum time a lot better.
Absolutely. Absolutely. Yeah, and we may have the relationship and the rapport with the patients, to be honest. I think that noticing, picking up on those cues can make a huge difference. So we're going to come back to the second question again and see how our audience is doing. for a learning check. So we're going to ask the question again. Which of the following recommendations is endorsed by ACOG regarding perinatal depression? So a core component of individualizing patient care is through evaluating social determinants of health. And Heather, how should we include addressing these social determinants when developing treatments with our patients?
It's of the greatest importance to integrate social determinants of health and how they impact patients into our daily patient care. And one big thing that I see in my practice is that if you don't do that, it's just not going to work out for the patient. Like, honestly, so many of my patients are impacted by all of these things. If you miss the opportunity to address these things, your patient will not get proper health care, period. It's just not going to happen.
And we'll end up calling them non-adherent.
Exactly. So like one of the big things I like to talk about, so for example, education, everybody has different literacy levels. Everybody has different health literacy levels, right? So you need to be speaking to your patients in a way that they can understand you, providing them resources in a way they can understand in their literacy, at their literacy level, because something that I often see is people will say, oh, well, I gave them handouts or I gave them information, but if they can't understand what it says, like if it's not in their language, if it's not in a language that written in a way that they can understand, that's a moot point. So saying you gave somebody postpartum instructions or ways that they can take care of themselves, but they don't understand what you're saying, it's a moot point. Other things too is like adherence, in quotes, to coming to medical appointments, right? If you don't allow children in your facility for whatever reason, that can harm, it can hinder the way in which people come to access care to you. Additionally, if people work, not having hours that are accessible, those are things that all matter. And then another thing that I notice is just even not being kind of flexible in terms of when people can come to you, if they're late, if they're, going to come a different time. These are all things that matter and we need to think about. Also, insurance coverage. One big thing that's happened in New York that's interesting, which I'm sure has happened all over the country, is there have been changes in what certain Medicaid coverage covers in terms of medications. Even when it comes to prenatal vitamins. So I've definitely had patients come to me after, you do your song and dance and congratulations, you're pregnant, and you write them their scripts. And I'm like, okay, I'll write you for some prenatal vitamins. And I see them weeks and weeks later. And then I'm like, okay, so how's everything going? And they haven't picked up anything because, it's not covered. And I've heard people say, well, why can't they forego XYZ thing in order to afford their medications? That's not really the way we probably should be approaching that. We should be trying to figure out how can we provide these resources, these meds to people who don't have it, instead of questioning where and how they spend their money, and then just even who, do these people get quiet moments, right? So when we're saying you need to not be stressed out, you need to relax. What if they live in a 1-bedroom apartment with 7 other people? That is highly common in urban areas, right? And so you're telling people that they need to keep their stress down because they have they're going to get preeclampsia, they have high blood pressure, but how can they realistically do that? So we need to come up with better ways and figure out how we can do that. We can help people get through that, and that's through providing different resources. So as I said, we have an army, we have a team of people that we can use. That's not just us, to help our patients do better. So we can talk to them about what kind of supports they have, who in their lives could help them. If we see a hole, figuring it out, because that's the reason why I lean on my social workers so much, because they tend to have a lot more awareness of different opportunities. Thankfully, in my case, a lot of the social workers actually can link people up with doula care and link them up with different things. But those are the types of things that you should be talking about with your medical practice, with your hospital system, with those types of things, because we really need to make sure we're fully supporting our patients. But also too, even the foods they eat, everything is affected by this. And we have to remember that when we're talking to our patients. So, assuming that they can buy whatever food that they're gonna have enough money to do it, or that the stores in their areas are going to carry it. Like, you have to change your whole focus and your whole plan, because we can't have people try to continue to adapt to what we think is what they should be doing. We should try to adapt a little bit more to where people are.
That's
And I
exactly
think
right.
that food piece is so big, because there's the whole cultural component that goes along with what we eat and how we eat. And so it's easy to tell someone, you need to follow this diet, you need to eat these things or not. We really have to go deeper. I think it's a wonderful model that Dr. Irabunda is describing in her practice. And I wish that that was more widespread, because that's exactly what it takes, being willing to dig deeper. And then once you dig deeper, displaying the fact that what you have uncovered matters. So here's what I'm going to do to meet you where you are. This is what you're telling me. Here's what we can do. And it does take a team.
Mm-hmm. One of the things I think is really important is that there are individual providers who have been advocating for this kind of care for a long time. But what we're starting to see is that national organizations and institutions are recognizing that this is really important. And so the National Academy of Science, Engineering, and Medicine has these 5 A's of how to incorporate social care into regular medical care. And so those are awareness, adjustment, assistance, alignment, and then advocacy. So thinking about the social determinants of health and how we're screening for those, how we become aware of these needs, how we're adjusting our practice to address these needs, how we're aligning how we deliver clinical care to meet our patients' needs, and then how we're advocating for these larger social issues outside of medicine, along with social service agencies and other advocacy organizations. So I think that there's we're at a unique sort of inflection point in our sort of healthcare, health policy history, and that this is becoming not just, the Black people talking about it, or the health advocates talking about it, but large institutions and government institutions that are recognizing the importance of addressing these issues for everyone, but particularly marginalized populations. So thank you, ladies. It's been such a robust conversation. Heather, I'm going to loop back and say that during pregnancy and following birth, Macy has had a difficult time emotionally. So we're looping back to the patient case. What can you tell us about her mental health status?
So Macy's OBGYN evaluates her for postpartum depression with the EPDS, and Macy scores a 19. So that meets the criteria for depression. And she is prescribed sertraline and directed to follow up in 3 weeks. She's also provided information on other resources available to her, including behavioral therapy, telehealth appointments, and postpartum doulas. And so I'm actually happy that this instrument was used. So the EPDS, which is the Edinburgh scale for postpartum depression and peripartum depression, we use this often. It should be used at the first visit. I usually do it around 28 weeks, and then I do it at the postpartum visit. And from then you can also see if there's been any changes in a patient's like affect or depression or anything like that, and you can identify issues. And so I'm glad that she was treated, but not just treated, but also given other information, because a lot of times, again, we're told like very clinically, like, okay, she takes the EPDS, she scores high, like reflexively like offer her medications, and and medications do help, and so we need to also destigmatize things like that. But we should also be talking about what are other things that are like causing the situation to be worse, right? Because to me, something that I felt kind of really like get really discouraged by sometimes is people just giving the medication and just and not really addressing any of the other things. Not asking her if she would like to talk to somebody, a therapist. Does she need some support? Does she just because a lot of people feel isolated, especially in that postpartum period. And so a lot of times talking through some of this stuff can be helpful. And because of barriers that we may have to getting people, especially like behavioral therapy, health therapy, like behavioral health is also a crisis in this country. And finding therapists, especially therapists that take Medicaid or don't take insurance and have a sliding scale is really hard. And so trying to find other resources, support groups, postpartum doulas, things like that, people who can help patients like Macy get through this is important, and not just, the medication. And then also close follow-up with us. So like not giving her the medication and say, see ya, go see your like primary care. Yeah, go see your primary care doc, like good luck. You know what I mean? It's like making sure you have close follow-up. I usually see my patients about like 2 weeks later. Not that I know that the medication is going to be working for her by that point, but I just want to see where she's at. You know what I mean? And also for her to know that someone's like looking out for her. Somebody is like wondering, how she's doing and expecting to see her, because what I've heard from so many patients dealing with postpartum depression is that act in and of itself, having an appointment like in 2 weeks where they know someone like cares if they show up or not is a big deal.
I think it's the same with postpartum doula support, because, you can't have someone from your doctor's office or midwife's office call you every single day, but we can. As doulas, we're able to fill in the gaps between care, which is why it's so important for doulas and medical professionals to not see each other as, on opposite ends of a spectrum, but rather as parts of a team, and we all have the same goal. And if we see it that way, we can better work together, understanding that a lot of times, compliance that clients of mine may be displaying is due to conversations we've had when they've left this appointment totally doubtful and committed to, no, I'm not going to do that until we talk through it. Because we built that relationship with them, and we are able to meet with them every single week. We're able to go to their home and be there and sit with them. So I think it's important that, again, that we have the team, and definitely underscoring what Dr. Irabenda said about, the medication, yes, but what else? Because the medication isn't getting to the root of the problem. If we see this person as a whole person, then we can recognize, part of the problem is, you have a lack of, groceries or resources in your home. Maybe we need to connect you to some services that can change that. Or maybe you need some job training or job placement assistance or something else. Or maybe you need a support group, something beyond that medication that's going to begin to help see improvement in their whole lives.
Yeah, where the additional psychosocial stressors that may be triggering this.
Mm-hmm.
Well, there are a lot of things that were offered to this patient, which were great. And one of the things that's newer for us as a country coming out of the pandemic is telehealth. And so that sounds like it may be sort of a good match for Macy, given our shortage of mental health services. And so one of the questions, so we have our third audience response question. Which of the following statements, I'm going to ask the audience regarding the use of telehealth for postpartum depression is true? So switching gears a bit, Sierra, you were just talking about the importance of having a multifaceted team and having the doula and the provider and social workers all working together to sort of form a bond around a patient for ideal care when it comes to pregnant and postpartum patients. What can you tell us a little bit about, do you think a team-based care model should consist of?
So there are a lot of programs that exist now to provide free or low-cost doulas on a sliding scale basis or on a scholarship basis. And on the surface, those programs are wonderful. They are, they appear to just bridge a gap where we need a gap to be bridged. The sustainability of programs like that is what concerns me as a birth worker. I've been a birth worker now for nearly 10 years. And what I have seen is programs like this that come in, and it's exciting for the public. But when you consider the effect that it has on the birth workers who are a part of those programs, we can understand why these programs are not easily replicable. Oftentimes, doulas are offered very low wages to cover these births, and the amount of work that's involved in working with folks who sign up for the majority of these programs we're dealing with some compounded situations. And so you have doulas who are here to serve and want to serve, but are being paid pennies for the work. And I think a solution to this that I see and that I've been very vocal about in terms of policy here in Texas is simply bringing doulas to the table when we are crafting policy that involves these types of programs. We can talk about what works. Many of us are ourselves offering services at a sliding scale or taking on pro bono clients. And there's certain ways that we do that and that we make it work. But I think when we talk about issues of equity, we can't ignore the fact that oftentimes those are creating more issues of inequity by paying someone, a lot of times less than a third of what the going rate is in that state for a doula. And so looking for other ways to fund doula support is huge for me. I know when I take on a pro bono client personally, I encourage that person to apply for a scholarship. The Baby Dove Foundation is the one that I send most folks to. And there's many others that exist, the Victoria Project based in California. And these are organizations who are committed to fair pay for birth workers. And so they offer training and they offer placement and they offer that fair pay, which makes the difference. And then you have a program that folks want to sign up to participate in. The other aspect of a lot of these programs is making sure that the doulas that are a part of the program are also a part of the communities that we aim to serve. That makes a difference. If we have this program, but I still can't get someone who I feel speaks my language, who understands my cultural experience and the impact that that's going to have on my pregnancy and my birth, my recovery, my life, how successful is that interaction going to be? And in those types of cases, we see the opposite of what we're hoping for, which is someone who is able to help this person open up in ways that they need to get the help that they need. Well, there's a care provider who's going to provide your primary medical care during pregnancy. It should be someone that you trust, someone that you feel is listening to you, is validating your concerns, someone that cares. You also need a doula who can bridge the gap and provide more emotional support, provide support in other ways, hands-on, logistics as you prepare to bring a child into the home, as you prepare to go into postpartum. It's important that you have some type of educator on your team. That may be a doula, or it may be education that you seek from somewhere else. Childbirth education, though, is something that I think is overlooked far too often, and competent childbirth education, I will say, that addresses things such as what Macy went through in the beginning, where she felt like a failure because she had a C-section. Then there's also definitely the need for a mental health care professional on your team. Having a therapist during pregnancy that you already have a relationship with, that you can continue seeing in the postpartum period, is really important. And I also think that it's important that those who are in the home with you, that you see them as a part of the team and you evaluate their role and how effective is this person? Are they, helping me, or are they causing more harm? What should their involvement in this situation be? But understanding that our goal is to get both the birthing person and the baby to come through in the most optimum health possible in every way.
Absolutely. I think it's important that you sort of noted that sometimes people in the home may not necessarily be helpful. We always sort of think about family equals social support, but sometimes family or people who are living in that space may not be, they may be drawing resources from that individual, or just frankly harmful to that individual. So assessing.
Oh, absolutely. Yeah. And that's something that, can be usually pulled out of a conversation if you really hear what the person is saying in between the words that are coming out of their mouth. Sometimes home is a place of stress. It's not a place of peace. And, if you have no choice, when it comes to where you live during pregnancy or in postpartum, then, you're going to be in a situation of stress each time you return home.
Yes.
And, unfortunately, that's the reality for so many people. So having that doula support can really I mean, for some people, it's the emotional aspect of it that is everything. That's absolutely everything. Having someone that you know cares, and not only do they care, but they're knowledgeable as well. And so you're able to come. I tell folks sometimes it's like having a really good friend who just so happens to have a
Training.
special expertise in all things pregnancy, birth, infant feeding, what have you.
Absolutely. So this is really important, sort of thinking about all the people that are part of the care team, but there are also additional resources and organizations that can equip patients with information and support and resources to achieve better maternal health outcomes. So Sierra, can you tell us a little bit about some of these organizations and resources that they can provide?
Yeah, so organizations like the Shades of Blue Project, where folks can come and get social support, they can get resources they need in the form of things like diapers and wipes, to provide immediate needs. But beyond that, we're looking at their mental health, and so we have support groups available. We have access to therapists at no cost. Through our programming. And, we are one of many programs that exist like this in the country. We center Black birthing people in the work that we do. And we exist because all of us in leadership are ourselves Black birthing people. We have been at one point or another, and our stories vary. The stories from our pregnancy year vary. My pregnancy year, me, when I had children years ago, didn't look like the me now. And I still remember everything I went through. I remember myself being a mom on Medicaid. I remember myself having to get rides to get to prenatal appointments. And I definitely remember the stress from knowing that, I really needed to, here in the state of Texas, you have to attend a minimum number of prenatal appointments, or else you are recommended for a CPS case. How stressful is that to have as knowledge, as a Black birthing person, knowing all we're up against, and then knowing that as well. And, you all mentioned earlier being labeled non-compliant. I was so concerned about that. And, I remember those things, and I remember what that felt like, and it informs everything I do in the way that I care for folks. And I think that's the wonderful thing that I see about the organizations and the individuals who are doing birth work right now. It's coming from that place, from
Yes.
remembering that I'm a human being and I'm here to serve other humans who are having very human experiences.
Yes, yes, who are having challenges, and how can I give them love and support,
Mhm.
and encouragement as
And even
opposed
just
to
listening and being willing to say, I hear you speaking, fellow human being.
yes,
I hear you, and what you're saying is registering with me, and it's actually motivating me to action, whether it's just a referral that I give you to see someone else, or whether it's, okay, I hear what you're saying. Things didn't go well with you last time when you were on that medication. Let's see what else we can do.
yep.
But just being willing to listen.
And that goes so far, as we know from being in those places ourselves, that when you are in a place of need, a helping hand, someone who just stops and cares, it makes the world of difference. It seems like someone is doing just, so much more than the simple act that they are. And so all of the work of these organizations and that you're doing is just incredibly important, and so meaningful. So thank you for that. We're going to go back to our third audience response question. We always ask each question twice. And so this one is regarding the use of telehealth for postpartum depression. And then Heather, we're going to loop back once again to Macy, our patient, our ongoing patient. How is she doing? What's her status now?
Okay, so Macy on her 4-month follow-up is doing very well and reports feeling calmer and happier. She
Yay.
tolerated the medication well and was able to work with a postpartum doula. So it sounds like she had more than one person on their team to help her through this. And then also the medication helped her. So it sounds like, a win for now.
I feel excited for Macy, like she's a,
I
a real
know,
person that we've helped
I
through her
know.
challenges. Thank you, ladies. All right, so we're going to summarize our discussion with our SMART goals. And those are goals that are specific, measurable, attainable, relevant, and timely. So that is what I hope you'll take from this presentation to apply to your practice. So first, recognize the widespread impact of the post-Roe world on pre-existing maternal health disparities and inequities. Next, inquire about a patient's mental health status, both during and after pregnancy, to reduce barriers to care and formulate an effective treatment plan. Also, assess each patient's social determinants of health with awareness, adjustment, assistance, alignment, and advocacy. And then finally, use a team-based approach to care to provide emotional, physical, and informational support for patients and their families. Heather and Sierra, are there any other action items that you'd like to add that I've missed?
I think you hit it.
Great. Thank you all so much again. Here are just some of the topics that we've covered so far, and we'll be adding new content every month. We really want to hear from you, our audience, on what you need so that we can make an impact on these very important issues. Please email us at questions@cmeoutfitters.com with your comments and feedback. We assure you we read every email, and we really appreciate your feedback. CME Outfitters also has a diversity and inclusion hub with a number of excellent resources to share with your patients. So thank you again to the faculty joining me today. You all have been awesome. It has been so much fun. Thank you, thank you, thank you. And also to our audience for joining us. Please be safe and take care of yourselves so you can provide the best care for your patients.